as well. Okay, perfect. So back to what I was saying. So they all mean the same thing. Alex and I are predominantly going to use the term cannabis today, but you will occasionally hear these other terms crop up, and you are welcome to use whatever term you're most comfortable using. There are a lot of different connotations with these different terms. There's a lot of different history behind them, but please use what you are comfortable with, and feel free to ask us any questions as well about what some of that different history is. So today we are going to start with a little overview of the Washington Poison Center and then dive into cannabis use under this lens of older adult use and health considerations. So we'll provide a brief overview of what cannabis is, what those main components are in cannabis, and then we will move on to a short section on legality. We cover legality because it has a lot of really important implications for what we understand about cannabis, what the current research is, and what's really available out on the market currently. Alex will cover modes of use, and then we will dive into those health considerations. We will start with more of the acute effects of cannabis use, so the short-term, in-the-moment effects, and then we will talk about some longer-term health considerations. I'm seeing we have comment here saying that there's repeated echoing and repetition. Gina, I'm going to unmute you. It looks like you had your hand raised as well. Oh, okay. Perfect. I think you might have been logged in on 2 devices, so that could have been what was causing that echo. Okay, great. So I'm going to turn it over to Alex now to start with talking about the Washington Poison Center.
Perfect. All right, so we'll keep this pretty short. We just want we want our services to be on folks' radar should you ever need it. We'd love it if you never had to give us a call, but we'd rather you know how to do it if you need to. So let's go ahead to the next slide and show the number. So our one big action item for you today is to record this number, put it in your phone, put it in a big sticky note on your fridge, whatever it is. But this 800-222-1222 number, this is the National Toll-Free Poison Center Helpline. Now, if you ever have to call this, what'll happen is it'll route you to your local poison center based on your area code. Doesn't really matter which one you get routed to, though, because they all provide the same services. They are all always open. It could be 2 p.m. or 2 a.m. Someone's going to answer. Services are totally free. You don't have to worry about billing or insurance or anything like that. And it's confidential. They're going to ask you for some personal information in case they have to follow up with you, just to make sure you're doing well. But any information you give to us stays with us. The same laws, those HIPAA laws that apply to hospitals and healthcare facilities, apply to us as well. And then we do provide interpretation services in over 260 languages, just in case you have a language other than English that you prefer using. Now, if you ever do have to call us, you can call just to get information on something. It doesn't have to be an active emergency. We'd rather take a call that could prevent a potential poisoning if we can. Doesn't mean you can't call us during an emergency, though, and that can be for little kids, that could be for adults, that could be for older adults. We get calls about anyone and everyone. So please keep that in mind. If you can't remember the number after this slide, it'll be on pretty much every other slide. So no concerns there. All right, next slide. We are going to now dive into a little bit of an introduction on cannabis and sort of how it works, so you know what the heck we're talking about when we go into the legality section. All right, so cannabis, first and foremost, is a plant. This one plant can be used to produce all sorts of products. It can be used to produce a bunch of non-drug products. We typically call this particular form of cannabis hemp. Megan will describe that in a little more detail in the legality portion. But this same plant, cannabis, Cannabis sativa is the scientific name there, can also be used to create a bunch of different drug products. Some of these are intoxicating or psychoactive. Some of these don't seem to be intoxicating, may not be a psychoactive. There's a huge range there, and they're all called cannabis. All right, so the endocannabinoid system. This system is in everyone. Every human, every mammal has the endocannabinoid system in them. doing its thing. We define it as a very generally, it's what we call a neuromodulatory system. So that means that it intersects with and interacts with all sorts of other neurological systems. It kind of acts as a bit of a regulator, as the name implies. It tells certain systems to take a break, to calm down as needed. Now, a cannabinoid, this is just a general term for a chemical compound that specifically acts upon this system, the endocannabinoid system. Now, most cannabinoids that we're going to talk about are actually what we call phytocannabinoids. They're plant-based, and they typically come from cannabis. They pop up in a few other plants. Cacao, that's what we get chocolate from. Echinacea, they have cannabinoids in them, or things that look a lot like cannabinoids. We also have what we call endocannabinoids. Again, just like the name of the system. These are in you right now. You could go your entire life without ever using, touching, smelling, seeing cannabis, and you have these endocannabinoids as a part of this neuromodulatory regulation system. And we're learning more and more and more about this system and these specific cannabinoids all the time. Today, we know of over 100 different cannabinoids, but we're mainly going to talk about 2 today. So you've probably heard of these, THC and CBD. THC is short for delta-9 tetrahydrocannabinol. Say that 5 times fast. This is the main intoxicating cannabinoid or component of cannabis. This is the main thing that contributes to someone feeling that physical high, that physical intoxication. Now, CBD is cannabidiol or cannabidiol. It's generally not intoxicating, at least not to our knowledge. Science is kind of all over the place on CBD right now. Some folks report that it can be intoxicating in large doses. What we do know about it, though, is that it can alter the effects of certain cannabinoids and certain other substances. So if you ever hear this term called the entourage effect, that is referring to this phenomenon where the interaction of these different cannabinoids can lead to different effects and different results than just them used on their own. All right, so keep this in mind as we go through regulation, as we go through the modes of use, that all cannabis products, regardless of the combo of cannabinoids they have, regardless of the route they get into the body, they all affect the endocannabinoid system. And that can be whether it's dried flower, that's a less processed form. That could be concentrates, which typically have a much higher concentration of THC and other cannabinoids. That could also be these all other forms, tinctures, edibles, and we're getting more all the time. We're getting topicals and medications. But keep in mind, they all interact with the endocannabinoid system.
Great, thank you, Alex. So we'll move into regulation now. And remember, if you have any questions, you can use the raise hand on your attendee control panel, or you can pop those questions in the chat box, and we're monitoring that closely. So now that you have those really basic definitions under your belt, we're going to talk briefly about the current status of cannabis, both nationally and then here in Washington. Because as Alex will talk a little bit later on, regulation has a really big impact on what we currently know and what we can do with cannabis. So cannabis legality, it's pretty convoluted here in the US. We don't really have the time to go into it all today, but essentially, cannabis was legal until 1970, when Nixon signed into law what was called the Controlled Substances Act. So this established the schedule system. So the feds decided that cannabis was what's called a Schedule I drug, meaning it had no currently accepted medical use and a high potential for abuse. There are a lot of other substances that are in this Schedule I category, like heroin and LSD, ecstasy, meth. So cannabis at the federal level is still a Schedule I drug, meaning it is still federally illegal. But even though it was deemed illegal federally, even though it was deemed not to have any medical use on the federal level, states really, they started to have a movement towards legalization. There were many people that thought that there could be therapeutic uses of this substance, and they were really pushing for legalization in a medical sense. So State legal movements began with medical marijuana being legalized in California in the early 90s. Washington, we weren't far behind. We legalized in 1998 for medical marijuana. Then, a couple decades later, the retail cannabis movement began, with Washington and Colorado being the first two states to legalize retail. So we have this line here that this categorization of cannabis limits available research. There's, because it's still federally illegal, it's really hard to conduct research on cannabis. There is one single university lab that can supply cannabis for federal research, and it's a very low potency THC. So it's not really reflective of the products that are out there today. And so it's really difficult to really gather knowledge and gain information about the cannabis that is being used today in these legal state markets. Okay, so we have a little time lapse here that's going to show us how momentum around legalization grew. So it's going to start in 1996. All of the states that are in gray have no legal market. The states that have blue have a legalized medical system, and then the states with green, which will pop up later on, are legalized retail systems. So we begin here in 1996 with California's legalization of medical. And then we have Washington and Oregon and a few other states pop up with medical. But it's not until around 2010, 2012 that we see more medical, and then retail starts popping up. And then all of a sudden there's a whole bunch of green that starts popping up all over the place. A lot of states that have moved to legalize retail cannabis. So currently, we have 34 states that have a medical system and 15 states and Washington, D.C. that have a legalized retail system. We're going to get into the distinctions between the two of those in just a couple slides. But first, we have to talk about CBD because, of course, it just makes the whole legalization context and information even more complicated. So in 2018, the Farm Bill removed hemp from the Controlled Substances Act. So it made hemp no longer a scheduled substance. Now, in this Farm Bill, it defined hemp as cannabis with less than 0.3% THC. So very, very low amounts of THC in it. Because the Farm Bill did this, we saw basically an overnight explosion of CBD products that are derived from hemp. So these products became available everywhere. They didn't have to be in the licensed retail cannabis stores. They were available now in just regular pharmacies, grocery stores, gas stations, all over the place, because hemp was no longer illegal. So folks could produce these products extracting CBD from these from hemp plants. Now, the thing with this new legalization of hemp is that it made products based off of hemp not very regulated. There weren't systems in place to make sure that these products were following certain quality measures, safety measures. So we like to tell folks that CBD products, you can purchase them actually within Washington's legal cannabis market, within our retail system. And that tends to be a lot more robustly regulated. So the quality of products tends to be, or may be better, or you might be more sure of a quality of a product within the licensed retail market. All right, so what is our retail system? So we legalized in 2012 with Initiative 502, or I-502. This initiative meant that beginning in 2012, cannabis could only be legally purchased from licensed retailers. And those people purchasing, possessing, or using needed to be at least 21 years old. We also put some purchase limits in place based off of different products. Now, I-502 and the laws that stem from it made other things illegal as well. And you might be aware of some of these. You might be surprised by some of these. So it is still illegal to use in public. It's illegal to drive under the influence. Washington, it is illegal to grow at home. We're one of the few states that does not have a legal grow program. The exception to this is with medical marijuana. Some licensees can grow at home, but I think it's in like a co-op type situation, so it's a little bit different. It is illegal to take cannabis across state and tribal lines. This surprises a lot of people. So, for example, Oregon also has a legal retail system, but it is illegal to take Washington cannabis into Oregon or vice versa. Same goes with tribal lines, even if a tribe has legalized cannabis on their lands. It is also illegal to use on federal lands, waters, or any federally funded property, because remember, cannabis is still a Schedule I drug at the federal level. So folks can't take cannabis into Olympic National Park because that is federal land, so it would be illegal to use there. Now, in addition to the retail system, we also have a medical marijuana system in Washington. So accessing the medical market is different than the retail system, where really to access the retail system, you just need to be 21 years or older. For the medical system, you need to have authorization from a healthcare practitioner. And in order to get that authorization, you have to document that you have received what's called the medical standard of care for a qualifying condition for 3 months. So essentially, you need to have a specific condition and you need to have tried other treatments for that condition before you are able to qualify for using medical marijuana. So those qualifying conditions are here in this red box. But we have two important things that we want you to take away from this. First, not all of these conditions have robust evidence backing up cannabis use for them. So that doesn't mean that cannabis won't help with that condition. It very well might help with that condition, but it also means that maybe cannabis isn't the best treatment for that condition. Second important thing, cannabis doesn't fix or cure these conditions. It might help with the symptoms of the conditions. So, for example, you see cancer listed there as the very first one. It's not going to cure cancer, but it might help with nausea stemming from cancer treatments. A little bit more on the medical system. So when someone is approved for medical marijuana, they are given a medical marijuana recognition card. So this card then provides access to a bunch of different things. So there are higher purchase and possession limits for folks with this card. There's no sales tax, but people still need to pay the excise tax. So there's still a little bit of tax added in there. As I mentioned earlier, folks with medical authorization have access to home grow of cannabis plants. And then perhaps most importantly, they have access to what are called medical marijuana consultants. So these are employees at cannabis stores. They're called bud tenders, kind of like a bartender, but they're bud tenders for cannabis. And these people have gone through training through the state to understand therapeutic uses of cannabis. So they are able to provide people with medical authorization advice on the products to purchase specific to their condition. Now, if you were accessing through the retail system, you very well might be accessing for therapeutic or medical reasons, but without that medical authorization card, you can't ask the bud tenders for advice or for consultation on what specific products to be purchasing. Okay, I'm going to turn it back over to Alex now for modes of use. Quick check-in first, though, to see if there are any questions from people. I don't see any in the chat box, but if you have any, you can raise your hand, pop them in the chat box.
All right, perfect. So yeah, modes of use. We're just going to give a little bit of an overview of some of the methods that folks are using for cannabis, which gives you a little clue as to what kind of products exist. So we made a variation on this point earlier, but just keep in mind that everything we go through, there is going to be a range of possible cannabinoids attached to them. So And this is just to build this example. We're just talking about THC and CBD now, but there's a plethora of other cannabinoids that can show up. So some are going to have focus just on one. They're going to emphasize one over the others. And some are going to have this big combination of them. Oh, I'm seeing a question. Let's see. If you move states like from California to Washington, do you have to be approved for medical marijuana again in Washington if you're already approved in California? Absolutely, great question. And yes, you do, because they are completely different systems that are built within the state for the state. They are non-transferable. And so that it's kind of an elaborate extension of that point Megan made. You can't take Washington cannabis into California or Oregon and vice versa. If you are qualified in one, that remains just within the one. And Megan, I actually don't know if you know this, what the renewal period is, how often folks in the medical marijuana system have to renew their authorization. I want to say it's every year or two, but I could be wrong.
Yeah, I want to say that as well. And also just to add on to what you were saying, the qualifying conditions can differ by state too. So even if you have a qualifying condition in Washington, that might not be a qualifying condition in California.
Yeah, and the barriers are different for sure. Barriers within Washington have changed over time before 2016 to after 2016. All right, let's go to the next slide. Okay, so smoking is still the most common method of cannabis use. And smoking is exactly what it sounds like. You take the plant material, you light it on fire in some fashion, and you breathe in the fumes, you breathe in the smoke. So pipes are really common, bongs or water bongs are really common. For those who don't know what a bong is, that's that kind of orange picture on the side. It uses water as a bit of a filtration system. I say that kind of loosely because water can only filter out so much when it comes to smoke particles. Then there are variations on essentially a cannabis cigarette. So joints, spliffs, and blunts. You also may be hearing my very vocal dog right now. So if she's coming through the mic, that's just my dog, Stevie. So something I'll say with the variations on these different types of cannabis cigarettes. Joints, it's really just cannabis in rolling paper. Spliffs and blunts are a little different. Spliffs will have raw tobacco, loose leaf tobacco, mixed in with the cannabis. And then blunts will be cannabis wrapped in cigar wrapping paper or rolling paper, not wrapping paper. And cigar paper is made from pressed tobacco leaves. So both spliffs and blunts do have a bit of nicotine in addition to the cannabis. And as little as we know about the effects of THC and CBD, we know even less about what they do combined with nicotine. Oh, and a little picture here. We always forget that we have animation sometimes. The top one is a joint, the middle one is a spliff, the bottom one is a blunt. Vaping. So first I gotta say, the vaping, the term vaping is a bit of a misnomer. Really, like, aerosolizing would be a more accurate term because vape implies that what is released is water vapor, when in reality it's a bunch of really tiny particles, so we call it an aerosol. Now, the idea of vaping or vaporizing or aerosolizing or whatever term you use is to heat up a substance just before the point of combustion, so before it catches fire and essentially you're smoking. Now, for most cannabinoids, vaporization begins at 350 degrees Fahrenheit and combustion begins at 465 degrees Fahrenheit. And there is a huge range in the types of vape devices. We can kind of organize them based on what they're vaping. So for cannabis, I had mentioned dried flower and concentrate earlier. Dried flower tends to have it's a pretty big range in THC concentration, anywhere from 5 to as much as 30% in the state of Washington, from what Megan and I have seen. Concentrates, again, as the name implies, have a much higher concentration of THC. There's a huge range in here as well, both in the THC concentration as well as in the type of concentrate. So if you ever hear of something called BHO or butane hash oil, that's referring to this kind of solid concentrate, sometimes called shatter, butter, wax, a bunch of other terms for that. CO2 oil tends to be in a liquid form, so that's that cartridge you see on the right side there. Okay, so edibles and drinkables. This is another method of cannabis use, and it's essentially eating or drinking cannabis in some form. So cannabis, THC, CBD, other cannabinoids can bind to certain foods in certain drinks. And so typically with Washington, the most common single serving dose is 10 milligrams of THC. So this package here of these kind of gummy candy called Marmas, this is 100 milligrams THC total in this whole package. Every 10 milligram serving has to be individually wrapped with child-resistant plastic, so kids don't accidentally get into this. So this would have 10 individually wrapped servings of this little gummy candy. Now, because there's such a range, and we'll get into this a little more with the health effects, but there's such a range with how folks react to a given dose. Some folks may take 10 milligrams and not really feel much. Some folks would find that it's way too intense and way too powerful. So we're starting to see more, there's more of a range in size now. So we're seeing 5 milligram or even 1 milligram single serving sizes. Now, kind of a hallmark with edibles is that, well, these 2 points here is that they take a lot longer than literally any other method to take effect, and they can have a longer period of intoxication than other methods. This is for a lot of reasons, but basically because it has to go through your metabolism, through your digestive system before it hits the bloodstream and thus the brain. There are a lot more steps in the middle rather than just breathing in fumes or aerosol or vape. This poses some kind of unique concerns with edibles. One of them is dosage. So especially for newer users who may be very new to using cannabis, they may take an edible, expect that it's going to hit them within an hour, and they don't feel anything for a couple hours, so they take another one. Well, by the time it's in your system, it's in your system. There's no getting it out. And so by the time both take effect, it's way more than they may have bargained for. Now, there's also a risk with driving. There's a risk with driving with any form of cannabis, mind you, but with edibles, someone may feel completely fine, and then it may kick in as they are driving or engaging in some other activity where they should have their coordination at max. All right, so one thing to keep in mind here is this logo, this Not for Kids logo. This is legally required to be on all edibles and drinkables packages in the state of Washington that have a THC content of greater than 0.3%. So the idea with this isn't to tell a kid, hey, don't go into this. It's really to educate the parents or the adults or the guardians in the home. If you have kids around, if you have anyone around who shouldn't be getting into cannabis, this is a reminder to store it safely. You'll also notice this has the Poison Center number here. So this came into existence out of a collaboration between the Poison Center, the Washington Liquor and Cannabis Board, which is the regulating body around cannabis in Washington state, as well as members of the cannabis industry. So kind of a cool point of collaboration there. There we go. And then we do want to acknowledge there are these alternative methods, and these are becoming more popular over time. We do have very limited data on them, though, but we'll go through and discuss at least a few of them. So we're going to talk a bit about tinctures and topicals, but also want to note that suppositories are becoming a thing, whether vaginal or rectal, and we're also starting to see more medications appear. So tinctures, they can be alcohol-based, they can be vegetable glycerin-based, and they are extracts of cannabis. So they typically have smaller doses, and they use this little kind of dropper style to administer under the tongue. They could be swallowed or incorporated into food and drink and swallowed, in which case they act a little more like an edible. But if they're put under the tongue, the membranes in the mouth, cannabinoids can absorb through pretty quickly. So generally, the effects would come much faster through that route than they would compared to an edible. Now, topicals, these are generally non-intoxicating. Cannabinoids typically can't travel through the bloodstream excuse me, through the skin to activate, to get into the bloodstream. To watch how I say that. So there is a big exception here, though. Transdermal patches will have additional chemicals added that'll sort of open those channels up. So someone could theoretically become intoxicated if using a transdermal patch. Now, again, there's a big range there's a big lack of research behind a lot of these. What we hear of, though, is that most folks report using them for sort of like local pain relief, muscle soreness, for tension, for inflammation, and the like. All right, so we're going to talk just a little bit about cannabis labels, because there's a lot to them and there's a big range with them. So let's go ahead and dive in here. So first, folks may have heard of this kind of classic breakdown of cannabis plants. So indicas and sativas. So earlier you may have caught me saying cannabis sativa when referring to this plant. That is the main type of cannabis plant that folks use for these various types and strains. Cannabis indica refers to kind of a cousin of that plant that is also historically used for various drug products as well. Now, this categorization of indica and sativa has kind of historically been used to describe assumed effects of these plants. The common assumption is that indicas will lead to more of what's called a body high. So folks report that it feels more heavy and focused in the body rather than cerebral, rather than in the head, and that this might be due to higher levels of CBD. And then folks will assume the reverse for sativas, that it might be more of that cerebral, like psychedelic head high, because it might have more THC. Now, because these two plants have been crossbred so much, and we have such an elaborately complex system of cultivation and breeding and crossbreeding these plants over many, many decades, it's very difficult to find what we call true indicas or true sativas, ones that haven't been hybridized with the other plant. So all that to say that even if you do see indica and sativa on a label, we're starting to see what's more common is to shift to this representation of cannabinoids and terpene content. And looking at the exact percentage rather than just assuming, it's an indica, so it's going to hit my body more than my head. That kind of thing. Now, terpenes, these are aromatic compounds from a whole bunch of different plants and fruits. They're not specific to cannabis, but they do show up in cannabis. Now, you might recall I mentioned earlier the entourage effect. Again, that's that idea that cannabinoids can interact with other cannabinoids to lead to different effects. Well, that can apply to terpenes as well. And so a lot of folks are starting to, or within the industry, are starting to report terpene content as well. Our favorite example of this is linalool. First, because it's so fun to say. Second, because it is the part of lavender that makes it smell like lavender. And linalool is an example of a terpene that can pop up in the cannabis plant as well. So this label here, I believe it's actually from Michigan or Minnesota, not Washington. But it shows, you can see these top few cannabinoids. So you see THC9, you see CBGA, CBDA. These are all different types of cannabinoids. But if you look at those bottom four, you see MYR, HUM, LIN, PIN. These are all different terpenes, and that you can see the percentage reported there. All right, just some additional examples of packaging. This is a very basic package for an edible. The product brand is called Doozy. So it's saying that each doozy, each single serving, contains 10 milligrams of THC and 2 milligrams of CBD. And then it shows where it was manufactured and all that, but it doesn't tell you more of a breakdown than that. Then you have this other example here, which tells you way more. This is an example of dried flower. And it shows you these three different cannabinoids, THC, CBD, and CBG. And it also goes a step further. We won't go into all this today, but it'll show you this further breakdown of what it calls active and inactive cannabinoids. And so it gives you this kind of total cannabinoid content as well as total active cannabinoid content. Feel free to hit us up with questions on that if you'd like. And it does say sativa, so you are still getting that representation of that sort of older style, but combined with the percent breakdown of cannabinoids. Just a little bit on CBD specific products. Now there's a range in how CBD is extracted. And so if you ever hear of a full spectrum CBD product, this actually is the least processed form. So it's likely going to contain kind of trace amounts of these other cannabinoids, including THC. Broad spectrum, the idea with this is to target and remove THC from the mix. So any and all other cannabinoids that were in that strain are going to remain in that strain. Now, an isolate is sort of the reverse of that. It's where CBD is what's targeted and separated from these other cannabinoids. But again, these aren't perfect processes, so there's likely going to be trace amounts of these other cannabinoids there. Now, just a little bit more on CBD. So Megan said this earlier, that the regulation or lack of regulation with CBD is all over the place. So because of that, there are a lot of potentially misleading medical claims behind them. There's a lot of uncertainty of the quality of a given product, if it's doing what it says it's going to do, if there's even CBD in that product. This picture here, this is just a sample picture we found from Bartell's Pharmacy, their website. And it's being promoted in all these different categories. So mood, pet care, sleep, and CBD may be effective for some of these, but we really don't know. The state of the research is just too ambiguous for us to back many of these claims, if any. So just be kind of cautious when it comes to purchasing and using CBD.
Perfect. And the only thing I would add here too is that the CBD products outside of licensed retail stores, they're not typically tested as often. Some of them might be, but the regulation just isn't there. And so the concentration of CBD might not be reliable. It might not be what's listed on the package. It could be exactly that. There could be no CBD in it. When there's been testing done, it's kind of been all over the place. So to just be careful with doing research on what the different products are and if they have undergone any sort of testing. Okay, we're going to move on to acute effects now and just check in quickly to see if you all have any questions. We're moving through this at a great pace, so we have plenty of time to address any questions that you have so far. I'm not seeing any hands raised, so we can move on, but yeah, feel free at any time. We got lots of time here today to talk about stuff. Okay, so we're going to move into the health considerations with cannabis use, and we're going to start with just looking at the acute effects. So the short-term, in-the-moment effects, like right after someone has used cannabis. Now, we like to start with this slide on increased potency. And we specifically start with this with older adult focused presentations because one of the commonly reported reasons for use among older adults is that they used to use back in the 70s, the 60s, and now they're starting to use again since cannabis is legal in Washington. Well, the thing to take away with this slide is that weed is very different these days than what it was back in the 70s. So this graph here, it shows how potency of products has increased over time. I apologize, it's a pretty grainy graph. It's a little hard to read, but on the far left, it starts in 1972 and it goes all the way up until 2016. And the line that increases, that is THC concentrations in products. So you can see that it has increased drastically since the 70s. It is a much stronger product these days. And the concern with that, with older adults who might be reinstating use after decades of not using, is that they might not be prepared for how much stronger this cannabis is. They might experience stronger symptoms, much stronger symptoms than they expect. They may not realize that it doesn't take as much cannabis as what it used to back in the day. Now, what are some of those symptoms that they might experience? So at the Washington Poison Center, we have our own breakdown of symptoms. And we like to first just remind people that there are different routes of exposure where people can experience these symptoms. So inhalation, ingestion, absorption. The severity of the symptoms that someone experiences depends on a lot of different things. The amount that they were exposed to, the concentration of the product, and then just the individual themselves, what their metabolism is like, how their body reacts to the substance. But in general, we have these symptoms for cannabis use. So they can range from mild to moderate to severe, just really based on all those factors I already mentioned on the individual and the amount that they have consumed. So someone might experience sleepiness or lethargy. They might experience euphoria, so just feeling really good. Impaired time estimation is a really interesting one. So someone might think that it has been hours, but in reality, it's only been 30 minutes. Their sense of time is just very messed up. They can't track the actual amount of time that has passed. Someone might lose social inhibitions. They might experience altered mental status, decreased motor coordination, and increased heart rate. GI upset like vomiting or nausea, dilated pupils, decreased tones, that would be like floppy muscles. And then in some cases, someone can even experience coma. Now, we've only seen this happen with kids who have gotten into products, and it's been in very high concentrations that they've gotten into, and it has not been a permanent state. It's temporary, but really anytime coma is involved, we get concerned. Now, you'll see that we don't have death listed on this slide at all, because there have not been any documented deaths by cannabis overdose. Now, that does not mean that injury or death can't occur because of intoxication. It just means that it's not like an opioid where someone can die from consuming too much. Now I'm going to turn it over to Alex to talk a little bit about our data at the Poison Center.
Perfect. Thank you, Megan. So this data here, this compares, it's actually the first 9 months of 2019 to the first 9 months of 2020. Because when we made this, that's the time of the year we were in. So what this is doing, it's looking at specifically THC exposures. We really didn't have very many CBD only exposures, so we felt it was best to focus just on the THC. And we look at these different age groups. So 0 to 5, 6 to 12, and all the way up to 60 plus. And in really every age category, there was at least some level of increase in our call data. This could be for a ton of reasons. Poison Center data is really fascinating because it can tell many different stories, but it is, and Megan mentioned this earlier, an underrepresentation of the amount of use of any given substance in the entire state, because there's no mandate for anyone to contact us if they decide to use cannabis for whatever reason. So typically this is when someone is alarmed or when someone's experiencing a symptom they didn't expect. And we'll go through some of the different reasons, I think, on this next slide here. So for little kids, age 0 to 5, generally, and this is regardless of the substance, most calls with little kids are going to be this unintentional or accidental category. And that's because kids like to explore the world with their mouths, which is alarming to those in charge of their safety. And so most of these calls are really kids saw an edible, popped it in their mouth. Kids saw a joint and popped it in their mouth. It doesn't have to be ingestion of an ingestible product. It could be of that dried flower, of a topical, or whatever it is. And then when we start getting into the teen years, we see more of this category we call intentional abuse. And this is intoxication-seeking behavior. And so this is someone was intending to get high, and it went too far, or they had more than they expected, or they had another symptom they didn't realize. And then misuse is an odd category, but it's essentially inappropriate use. So using something incorrectly. There. Go on to the next slide, I think.
I do actually want to point out something on this slide, since this is an older adult presentation. We didn't include all of the exposure reasons. for cannabis in all of the different age groups. And unfortunately for the older adult one, we didn't include unintentional therapeutic errors. So medication mistakes basically with cannabis, where maybe they have medical authorization, or they're using retail cannabis for some sort of medical use, and they've made some sort of error with it. There were quite a few cases. I want to say at least 30 to 40 cases that were unintentional therapeutic errors with cannabis.
Thanks for adding that. It's making me realize we need to update this particular graph to include that exposure region for this. The joy of having so many different subtypes of this slide deck. All right, so what were folks calling us about? Most of our calls, or the biggest category for our calls for 2020 specifically, were edibles, actually. And that could be for a lot of reasons. We do wager that having that Not for Kids logo probably was a big factor here. And we kind of wonder if this Not for Kids logo was required to be on all THC containing products, we expect we'd get more calls than the other categories, simply because someone may not think to contact the Poison Center if their kid ingested a topical or what have you. But that was almost half of our calls were for edibles. About a quarter of our calls were for the dried plant material. And then 15% for concentrates. And then we just have this elusive other category, which includes it can include medications in pill or capsule form, topicals, or even just unknown products. All right, so we hinted at this a little earlier, but we do want to dedicate at least a slide to this. Please don't drive after using cannabis. So cannabis absolutely can impair many very necessary skills for safe driving, including coordination, motor function, reaction time, concentration, focus, attention. We also want to acknowledge, so DUIs within the state of Washington and nationally, but honing in on Washington, are a little bizarre. Alcohol-specific DUIs have actually gone down fairly substantially over the last decade or so, which is a great trend to see. The concern, though, is that polysubstance, that means using more than one substance at once, these DUIs have gone up pretty substantially, and the most commonly combined substances are alcohol and cannabis, specifically THC-containing cannabis. And just to clear the air here, we do have more and more evidence over time that shows that it's pretty darn likely that cannabis and alcohol used together are going to bring about a greater degree or greater level of impairment than either substance alone. Now, there was a survey Megan and I were made aware of a couple years back from the Washington Traffic Safety Commission, and they asked a bunch of folks who reported that they used cannabis while driving why, and there were quite a few folks who reported and genuinely believed, oh, I use cannabis to sober up from alcohol so that I can drive more safely. And again, we can't emphasize enough, that is not a thing. Science does not back that in any way, shape, or form. Even if someone truly feels sober, bringing in multiple substances tends to reduce our ability to gauge our own sobriety. Just as a blanket rule, and that's absolutely true with cannabis and alcohol combined. All right, I think it's to you, Megan.
Yep, thank you, Alex. So because we're here talking about older adult use, we have to talk about medication management, because older adults tend to use a lot more medications than younger age groups. They have a lot more complex medication routines, and so it's really essential to make sure that this area of risk with cannabis use is addressed. So, as Alex mentioned on the previous slide, cannabis has cognitive implications. It can impair someone's their cognition, their attention, their short-term memory. There's actually some pretty substantial research out there that says that for those who report heavy cannabis use, so daily or near daily use, they are more likely to experience memory impairments for even up to 7 days. Now, these memory impairments, they don't have to be from heavy use, though. They can be people can experience that with their short-term use as well. Here we go. And then remember, I had referenced earlier that cannabis use can alter time estimation. So if someone is taking medications that are based or that require use being taken at specific times during the day, if time estimation has been affected, then they may not be able to as successfully take those medications at the correct times. So when we're thinking about all of these cognitive implications related to medication management, there can be a lot of concerns here, like memory around taking medications. Someone might be more likely to miss doses, or they might double dose because they haven't realized that they've already taken their medication, so they take it again. If they're taking a medication that requires some potentially complex medication instructions, how to use that medication safely and correctly, they might have a harder time understanding those instructions for use. There can also be drug interactions with both THC and CBD. So these two cannabinoids, they are both metabolized or processed by a system in the liver. And this same system metabolizes or processes a lot of other different drugs, common drugs that people take. Now, when the liver is trying to process THC and CBD, while they're also trying to process another drug that is being taken, something called a drug interaction can occur. So THC or CBD might block this other drug from being processed effectively. So it might build up that other drug within the body, or it might cause someone to experience different side effects from that drug or symptoms from that other drug. Or it might do the reverse, where THC or CBD build up more in the system and aren't processed as quickly. Now, what someone might experience then with those interactions could be increases in the amount of drowsiness. It might be more sedating for them. They might even have increased risk of bleeding with certain drug interactions. And then there can be effects on blood sugar as well and blood pressure. Now you'll see that we didn't list out the specific drugs on these slides, and there are a few different reasons for that. First, that the research behind these interactions is constantly changing. I mean, we look up things and then all of a sudden that website has disappeared. So it's constantly changing. And so it's a really complicated topic to dive into. And these interactions can also be very hard to predict. Sometimes it can be extremely difficult to tell if an individual is going to experience these sorts of interactions. So instead of us listing out potential concerns, we recommend instead to talk to a doctor, talk to a pharmacist. They might not know. This is, as I just said, a constantly evolving field. It can be really difficult to understand. So you can always call the Poison Center. Our nurses and pharmacists who work in the call center, they are very equipped to help answer questions about this. Alex and I have talked to them. We've asked them if they're comfortable with answering people's questions about drug interactions, and they said that they definitely are. So you can always give them a call, run through all the different medications you're taking, and ask about potential interactions with cannabis. Now, a final intoxication risk that we mentioned with older adults is the risk of falls. So we've mentioned these different impairments multiple times already with coordination and motor function, concentration, attention, and reaction time. These can all be affected by cannabis use, which can put someone at greater risk of falling if they're less coordinated, if they're not able to react to the circumstances around them. Those drug interactions can also increase risk of falls if someone is experiencing more drowsiness, if their blood sugar has been changed, if there's a sudden drop in their blood sugar, for example, as well as blood pressure. If their blood pressure has dropped a bunch, they might be dizzy, they might be more prone to falling. So what are some tips to make sure all of these things that we've just talked about don't happen, or there's less risk of them happening? First and foremost is to just normalize discussion of cannabis use. It is happening around us. There are people are using cannabis, older adults are using cannabis. There is a lot of stigma still around this. And so it's very important to talk about cannabis use If you work for an organization that works with older adults, make sure you're asking them about their use. If you are an older adult, make sure that you are talking to your doctor, talking to your pharmacist, or your service providers about your use. Really normalize that discussion. And then use medication management strategies. Discuss risks with healthcare providers and pharmacists or with the poison center, and then use some sort of organizational system to counteract some of those symptoms that could lead to medication errors. So organizational systems can be like a medication calendar. So when we send a follow-up email, I'll include these resources with our slide deck. But we at the Poison Center have a medication calendar, which is what's on the far left of the slide. It's very simple. You would just write down the medication name, and then after you've taken it, you check it off. So that way you have physical proof that you have taken that medication and you're less likely to double dose. You could also use just a plain wall calendar, phone calendar. There are a lot of cell phone apps that also can help with these physical checking off and reminders for taking medications. Using a pill organizer is another great system. So that could be bubble packaging from pharmacies, pill boxes, or fancier pill organizers. Pill organizers can really vary a lot in the level of support they provide based off of what a person needs. They might be really simple where you just pop it open, or there are others that lock until it's time to take a medication. Others have audio cues, others have flashing lights. There's lots of different levels of support with those. To check for interactions, it's really important to have a comprehensive and up-to-date medication list. So an effective list needs to contain at least the name, dose, time, and special instructions for every substance, every medication being taken. All your prescription medications, any over-the-counter medications frequently taken, vitamins, supplements, and cannabis or CBD if that is being used. And then take this list to every healthcare appointment just to make sure it's still accurate and they can check for interactions. Now, if you don't have a medication list, or if your organization is interested in having a resource to help older adults develop lists, I'll send this out. It's our development guide that walks you through a bunch of different questions on developing medication lists. Come on. Here we go. And then we also have worksheets as well for medication lists. So final thing here with acute effects is, what if someone is too high? What are you supposed to do? Alex and I get asked this question all the time, and we have heard some truly wacky ways people think can help bring down someone's level of intoxication. I think we've heard pineapple juice, carrots, taking a bunch of CBD. Well, what we want you to take away today is that there are no proven methods to decrease levels of impairment. What you should do is stay put, essentially, and wait for the effects to naturally decrease. Don't take any additional drugs. Taking a bunch of CBD after you have consumed THC is not going to help bring that level of impairment down. Don't drive or operate machinery. Be careful about falls. Have a buddy if you can, and then you can always call the Poison Center, and our folks in the call center can provide some additional advice specific to your situation. Okay, I'm going to turn it back to Alex now for some more longer-term health considerations.
Perfect. Thanks, Megan. All right. So before we go into some of the specifics, we have to define and just discuss briefly dependence and addiction. So whenever we say dependence, we're referring to this physiological process that occurs. And this process occurs when the body and the brain starts to rely on some external outside substance in order to maintain what we call normal function, for whatever it might be. So my little silly example of this is my own relationship with coffee and with caffeine. You've probably seen me take a swig of this thing quite a few times already in our session today. Now, when I was a kid, I hated coffee. I thought it was nasty. And it wasn't until I was in college that I started using it more, realized that, oh, wow, this thing helps me study a lot, helps me focus, helps me take tests. Now, the closer I would get to a test or finals week or the end of the quarter, the more coffee I'd have. And so I didn't realize at the time, but I was experiencing what we call tolerance, where I needed to have more and more and more of that external substance to maintain my normal function of focusing and studying and all that. Now, what happens with dependence, when this physical dependence occurs, reducing or quitting that external substance can actually lead to what we call withdrawal symptoms. So for me, in coffee, which was really a dependence on caffeine, when I would quit, when I would stop or reduce, I could get really tired, I could get irritable, I can get lethargic, I can get headaches. These are all very, very mellow, mild examples of possible withdrawal symptoms. Now, addiction is a very general definition, but essentially it's when that physiological dependence starts to become disruptive to other aspects of life. And dependence itself is a symptom of addiction. Now, we bring this up regarding cannabis specifically because it has been and currently is a lot of rhetoric that cannabis isn't addictive or doesn't bring on that kind of physical dependence, or at least if it does, it doesn't do so nearly as powerfully as other substances such as heroin or nicotine. And there's a lot to unpack in that. Like, heroin and nicotine are two of the most addictive substances that exist. So they're not great things to compare the addictive nature to. But a lot of folks who specifically use cannabis heavily, when they quit, a lot of the times they will report that they experience at least some level of withdrawal symptom. And withdrawal can imply dependence. Now, does that mean that every single person who uses cannabis is going to develop dependence or going to develop a cannabis use disorder or that addiction? No, not at all. But there is this potential risk, especially as these products become more and more potent, have these higher levels of THC in them. Now, for cannabis withdrawal, a lot of folks will report these following symptoms: sleep disruption, anxiety, irritability, depression or depressed mood, and headaches. Now, what can be really tricky with a lot of these is a lot of these reasons may be why someone is seeking out cannabis to begin with. So looking at sleep disruption, we'll talk a little bit more about it, but someone may take cannabis to help with sleep disruption. Say they develop this tolerance to it, they need more and more and more and more and more. They decide they don't like it, they're going to stop. They may develop even worse sleep disruption as a withdrawal symptom following it. So it could potentially create a bit of a feedback loop there. Now, there is a bit of a range with when withdrawal symptoms take effect. Depends on the person, depends on their history. It can be they typically start within a day or up to 3 days following abstinence, can peak after a few. They can last up to 2 weeks, depending on the individual. All right, so is there an older adult risk of developing dependence? Absolutely. And unfortunately, there is extremely little research on this. Most research on the effects of cannabis and cannabis use tend to look at younger adults, which, it tells us a lot about younger adult use and tells us nothing or very little about older adult use and the concerns there. Now, one aspect to this that's challenging from a research perspective is that a lot of the signs and symptoms of cannabis dependence, such as drowsiness, dizziness, memory impairment, falls, these could be common in older adults who don't have cannabis dependence at all. So that diagnosis can be really difficult. And we want to just acknowledge that stigma itself is incredibly powerful. And so for a variety of reasons, someone may feel ashamed of their cannabis use or other substance use, and because there still is a lot of stigma attached to any substance use in our society now. And one of the bigger messages of the Poison Center, something we try to integrate wherever we can, is destigmatizing language whenever possible, and to encourage folks to not only reach out to us but reach out to their providers to discuss cannabis use. Which brings us to a question I noticed earlier. I think this is a good time to bring it up. In case folks don't see in the chat box, someone asked, how do you convince older adults to talk to medical providers about their cannabis use if they're afraid or embarrassed? And I think a lot of that fear and embarrassment can come from this stigma. Now, I'm not an expert on how to convince someone to seek out care or anything, but one avenue you could go, and Megan, please chime in if you have other suggestions, is to encourage folks to contact the Poison Center because of that anonymity or that increased confidentiality. Folks may feel more comfortable initiating that discussion. Again, it could just be to seek out information. It doesn't have to be, oh, I took too much cannabis, now I feel weird. It could just be, hey, I'm considering using this CBD supplement in addition to my other medications. What can you tell me about that?
Yeah.
Is there anything you want to add?
Yeah, I think that's a really great start for folks, and I think it's really important to have dialogue with your regular healthcare provider as well, because at the Poison Center, I mean, we're not going to have, our call center is not going to have your same history of conditions and the complete picture of what all is going on with your health. But it can be really difficult to talk to healthcare providers about cannabis use, especially since knowledge about cannabis use is really, it can vary a lot among healthcare providers. I think my recommendation would be for an older adult to be really prepared when they go into having a discussion with their healthcare provider, to have knowledge about cannabis themselves and their reasons for use and why they're using it and how they think it's helping them. Because they very well might need to kind of educate their healthcare provider a little bit as well. If someone is nervous or scared about doing that, I think it's really helpful to bring an advocate to healthcare appointments as well, who can provide a little bit of strength for the older adults and also can help, help with that discussion some. So it's a hard question to answer, especially since every provider, I mean, I've talked to a lot of different providers about older adult cannabis use, and they're kind of all over the place with it. So I think the best thing is to just do some research, be prepared, dedicate some time to having that discussion, and bring an advocate. Hopefully that's helpful.
Awesome. Thanks for adding that, Megan. And yeah, we're definitely in such a weird state of transition right now where, more and more states are legalizing, but it is still a federally illegal substance. And until that changes, there's going to be this kind of tension there where there's not a mandate for providers to necessarily educate themselves on cannabis use. So I'm curious to see how that changes over time.
I have one more thing to add too.
Oh, please. Go ahead.
Some healthcare providers cannot talk about cannabis use. They can't advise on it at all because their facility receives federal funding. So just be aware of that. I think some of them will still be willing to talk in broader terms about someone's cannabis use, but they aren't able to advise on like specific uses or dosages or things like that. So in those instances, it could be helpful to then call the Poison Center if you need to have a more direct conversation.
Perfect. Thanks for adding that. All right. So next slide. So we're going to just talk, starting with some of the therapy evidence has backed right now. And all these statements we're going to go through, these come from these two different large reviews, one from the National Academies on Sciences, Medicine, and Engineering, and the other from the state of Colorado. And they're these very fantastic, huge, multi-hundred-page publications that looked through all the evidence they could find at that point in time, so 2017 and 2020, and then published them in these different statements. So this is the one and only conclusive statement you get to hear us say today, is that we know that certain cannabinoids are very good at treating nausea and vomiting for folks who are receiving chemotherapy. Now, these studies looked at these oral synthetic THC medications, nabilone and dronabinol. These are FDA approved. They have been for a couple decades now, I think. And so we know quite a bit about them. And while they are synthetic, they are not from the cannabis plant directly. They so closely mirror the chemical structure of THC that we feel reasonably comfortable in making the assumption that THC itself would be very effective at treating nausea and vomiting for folks undergoing chemo. Now, step down with the evidence here from we very likely know here that certain cannabinoids are very effective at treating chronic pain. Now, this evidence specifically looks at products called nabiximols. They are mostly a 1-to-1 ratio of THC to CBD, so close to equal parts THC and CBD. They are used or approved for use medically in Europe, in various parts of Europe. Oh, that's my pup again, getting very excited. They're undergoing trials in the US, but they are not approved for use just yet. So they may become approved at some point. Now, there are a few different mechanisms for pain and pain treatment. This is a very basic overview here. So pain that comes from tissue damage largely comes from inflammation. Inflammation is part of your body's natural response to heal itself. Now, pain that comes from nerve pain, this can happen totally outside of inflammation. And so treating these can kind of go down these different routes. Next bullet. So both these cannabinoids, THC and CBD, are very effective at reducing inflammation. There's still a whole bunch with this we're trying to learn. Sometimes the inflammation response is a good thing, and we want to keep that there. But sometimes, especially when it's attached to pain, reducing that can be very helpful. So THC, there is a bit of a concern with THC use in chronic pain, specifically because of the concern with tolerance and dependence. We haven't identified those concerns with CBD just yet. It may happen, but the science isn't there. The World Health Organization published a thing a couple years ago saying that they weren't really concerned about physical dependence concern with CBD. And now just on the idea of nerve pain, how both of these may be effective with helping with nerve pain, is that the cannabinoids may weaken the pain signal sent to the brain, and then back to that part of the body. And it may actually, there's this odd phenomenon that we can see in certain animal studies where if there's an injury or if nerve pain is occurring, we can start to see more endocannabinoid receptors develop at the site of pain, which potentially could have some implications about using cannabinoids to help treat that pain. So we get asked questions about, should I use cannabis instead of opioids for chronic pain? And that is a complicated question, and it's a complicated answer. Really, we need more research before we can say, yes, this is a good way to go, or no, this is a bad way to go. There are reports of folks who will try using cannabis to sort of wean themselves off of opioid use or replace opioid painkillers with cannabis. Cannabis itself is not risk-free, and sometimes prescribing opioids is the correct way to go, even with the opioid epidemic. So there's too much for us to like fully unpack here, but really we encourage folks to talk to a healthcare provider before trying to just replace pain meds with cannabis on their own. A little bit with sleep. I hinted at this earlier, so we probably know that cannabis use is correlated with improved short-term sleep disturbance. Now, the research here looked at these particular causes of sleep disturbance: sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. Emphasis on short-term, though. Can you go to the next slide? So both cannabinoids seem to be pretty good at this, both the main ones we're talking about, THC and CBD, but there's a concern, again, with THC and dependence, that it seems to be pretty good at reducing what we call sleep latency, how long it takes someone to fall asleep. But because someone may need to take more and more and more and more to achieve that same level of sleep latency, they may develop that tolerance. And that's something that's kind of true with any and all sleep aids, is that they're pretty notorious for folks developing a tolerance to. CBD is a little weirder. Some folks think it acts as a bit of a stimulant in low doses and a depressant in high doses. So in a high dose, it may be good at regulating sleep. But again, there's that concern with all the interactions that Megan mentioned earlier. There's this concern with what that might do to the liver and just unknown effects, because there's still a bunch we don't know with CBD. respiratory considerations. So this is our little like, we're not fully sure logo here. So we're going to talk about what we, some of what we know, which may seem a little contradictory. So we very likely know of this link, of this correlation between heavy use or near daily cannabis smoking specifically, and the development of pre-malignant lesions in the airway. Pre-malignant means precancerous. Now hold on to that for a second. We also can see that cannabis smoke and tobacco smoke share a lot of the same carcinogens, including ammonia and hydrogen cyanide. Again, carcinogen means cancer-causing. And we very likely know of this overall correlation between smoking cannabis and worse respiratory symptoms. This can include coughing, wheezing, phlegm development. All of this, just even with all of this though, we haven't been able to connect cannabis smoking or cannabis use in general to lung, head, or neck cancers, which is a little puzzling. I think a lot of us would expect, especially with these same carcinogens in cannabis smoke, that there would be this correlation with lung cancer especially. But right now, there's a moderate level of evidence that supports this idea that there's not a link there. But we do want folks to know that even if there is no link to lung cancer, that doesn't mean there aren't other issues that could develop with respiration, which is especially concerning when we're in the middle of the COVID-19 pandemic, which targets the lungs. A little bit on anxiety and depression. This research is largely correlational, so we can't say cannabis use causes anxiety or depression, but we can see a bit of an overlap. So we may know that there's a correlation between cannabis use and developing various anxiety disorders. We do have a little more direction, a little more strength behind this claim of depression, that we probably know that there is a correlation between cannabis use and the increased risk of developing depression or other depressive disorders. And this is a really heartbreaking correlation here with suicide, that we probably know that cannabis use is correlated with suicidal ideation, attempts, and completion. And that there seems to be what we call a dose-dependent response, that more use correlates with higher incidence of attempts and completion. We do have to emphasize, we cannot say that cannabis use causes suicide at all. What could be the case here is that the same risk factors that put someone at risk for cannabis use may also be contributing to their increased risk of suicidal ideation. We do have here the number for the crisis connections, the 24-hour crisis line, if anyone needs to contact that. And then on this next slide, this is the National Suicide Prevention Lifeline. So this is the national number. And then really for immediate help after self-harm with yourself or with another, bypass the Poison Center, and just call 911 immediately. To get that immediate help. Just a little bit on CBD. We're getting close to the end, everyone. Again, we're probably tired of us saying this. There is very little research on CBD. Most of the studies we do have look at animal studies. There's the human studies we do have look at like oral administration or inhalation, not topicals. So having this so much lack of regulation kind of contributes to this increase in the types of products, increase in number of products, and even more uncertainty as to what their contents are. It makes researching much harder when there's that much more to look at. Now, we do want to acknowledge the potential for CBD's therapeutic effects. There is an FDA-approved CBD-derived medication right now called Epidiolex. This was approved in 2018 to treat certain forms of epilepsy, and it seems to be pretty effective for that. Now, we mentioned the anti-inflammatory properties earlier. Because of those properties, there is hope that some folks have a hope that they could be used to help treat certain neurological disorders that deal with inflammation. And then there is hope that CBD may be used to help treat substance use disorder or addiction from various types of substances. Now, again, these all come from animal studies, so we're quite a ways from doing full human trials with these. And we talked a bit about this earlier. Megan mentioned the liver injury, and that CBD can interact with a certain enzymes in the liver that's used to break down toxicity. We want the liver working well. That is a useful thing to keep functioning nicely. I mentioned that World Health Organization publication, and really we just have this sort of last concern here that because there's such an abundance of misleading, of false, and just unproven medical claims with a lot of CBD products, one of our concerns is that someone would set aside seeking proper medical diagnosis and medical treatment and kind of delay that and use CBD instead. And even if folks find efficacy with using CBD to treat whatever it might be, we still encourage them to kind of coordinate this with their provider, with their doctor. Okay, we have made it to the very end. We do have a couple trainings coming up we want to put on your radar. When we send these slides, these links are hyperlinks, so you can follow these to register for these if you'd like. We have one on Wednesday, February 10th that evening on opioid prescriptions, keeping yourself and your loved ones safe. And correct me if I'm wrong, Megan, but one of our call takers is joining for this particular one. Is that correct? No, it's not. Never mind. I'm talking about a different one. Ignore me. Not too long after that, Tuesday, February 16th, we're doing a vaping 101. So we're going to be talking a lot about some of the basics of vaping. All right, once again, here's the Poison Center number. If you missed adding it to your phone earlier, here is your chance. And then I think the last slide is just our big thank you with our contact info. You guys are welcome to reach out with any additional questions, with any feedback. Also, if you'd like us to speak to a different group, a different organization on this topic, on other topics, we're happy to do that. We don't charge. We're free. So we're always happy to schedule something else if there's interest. So please, we've got about 5 minutes before we sign off. Feel free to hit us with any and all questions or comments as you have them now. Oh, getting one now. Will these webinars be available to view later? We are planning, so this is being recorded. Takes us a little bit to finally download the recording, but once that's all set, we'll send a follow-up email that'll have a link to download our slides as well as the recording itself. And we should have put this in the slide itself. We do have some of our presentations uploaded on our YouTube channel, so folks can access our YouTube channel. You just search for Washington Poison Center, and there are a few different ones that we've included in there.
And I'll put, we really have a bunch of upcoming trainings. So I'll put the link to just our catalog of trainings. And these are all open to anyone to join. Oops. Let me send that to everyone. So we'd love to have you.
Oh, wonderful. That's awesome. Perfect. Let's see. And then what's the quick link, Megan, for someone signing up for our just regular updates in the newsletter? I want to say the form is on our website. If we find that quickly, we'll add that in our follow-up email. So if you want to kind of stay tuned to see our upcoming newsletters, we can add you to our big email listserv. All right, folks. Well, feel free to, again, hit us with any and all questions. Feel free to log off. You don't have to linger for the next 3 minutes if you don't want to. Totally fine if you do, though. We'll stay on until folks start dropping off. And thank you very much for attending. It's always our pleasure to go through these and see. We kind of tinker with it every time and see what we like, see what we don't like. Wonderful. Thank you.